Are we ready, Caitlin?
Yeah, people are filtering in now.
Okay. Good afternoon, everyone. You are joining the Understanding Trauma Informed Care, and we are happy to welcome you to the Central Iowa Area Agency on Aging webinar series. We are going to give everyone just another couple of minutes, maybe 30 seconds or so, and we're going to get started here in just a minute. And so everyone hang tight, and thank you for joining us. Okay, and if you have just tuned in, welcome again to the webinar series that is sponsored by Central Iowa Area Agency on Aging. Some of our Zoom webinar features that you'll see posted on your screen today, you are automatically muted. You are not able to see the other participants. You will be able to see the speakers and the host. Please ask your questions via the chat box. We are going to hold questions, I believe, until the very end and then address questions then. But we will, I do encourage you, while you have a question, go ahead and put it in the chat box, and that way you won't forget, and we can go through and answer those in order at the end. The session today is being recorded, so we do want you to know that. It is available on the Central Iowa website after today. So if a colleague that you know wanted to see this, you can let them know that it was recorded and is available to view after today. And all of our resources will be posted on our website, and it is listed there, centraliowaaging.org. And it is my pleasure today to introduce to you our speaker today. Today we have, backed by popular demand, Kara Lemon is with us, and Kara is, in addition to being a good friend and colleague of mine, Kara is also a member of the North Carolina Geriatric Adult Mental Health Specialty Team. She's a licensed social worker and has a wealth of knowledge to share with us today. So without any further delay, I'm going to turn things over to Kara. And again, welcome, and we are very glad that you're with us here today.
Thank you, Lori. And yes, we are glad that you are with us today. As Lori said, I am with the North Carolina Geriatric Adult Mental Health Specialty Team, and this is what we do, is we provide trainings on mental health, substance use, and dementias. I do have a PowerPoint that I am going to share. Okay, we can see that well. Okay, very good. So we're going to start out by talking about trauma so that folks will have a better understanding not only of trauma, but the impact that trauma can have. We're also going to talk about why trauma-informed care, and then we're going to talk about exactly what is trauma-informed care. And we're going to end with a few very basic ways to implement trauma-informed care. This is very much a foundation training today. There is plenty more about trauma-informed care and how to implement it that we won't be going over today. So let's dive right in by talking about ways, words, phrases used to describe trauma. So trauma is witnessing or experiencing an event that poses a real or perceived threat to somebody. It is also an event that overwhelms the person's ability to cope with it, to endure it, to handle the experience. But experiencing a traumatic event does not mean that a person is going to develop post-traumatic stress disorder. Traumatic stress involves the nervous system, and it's where the nervous system has become overwhelmed by stress, triggering a wide range of intense emotions and physical reactions. It changes the mind or the brain by keeping the person on constant alert for danger, even though they might not look as if they're on constant alert for danger. Post-traumatic stress disorder is a mental health disorder or diagnosis that can occur in people who have experienced or witnessed a traumatic event, like we talked about just a couple of seconds ago. 10 to 20% of people who experience trauma or a traumatic event will develop post-traumatic stress disorder. And then there's secondary trauma. This is the presence of symptoms caused by indirect exposure to trauma. And that could be hearing people talk about and share their experience of a traumatic event. "61% of adults have had at least one traumatic event prior to the age of 18. That is according to a study, a now very famous study called the ACEs study, done in the mid-1990s. This study looked at different types of traumatic experiences that children can have. We'll talk more about this study in a little bit, but the one thing I will say up front at this point is the medical traumas, traumas from being in the hospital, surgeries, treatments, those types of traumas were not included in this study. So 61% of adults have had at least one traumatic event prior to the age of 18. 16%, or 1 in 6 adults, had 4 or more trauma experiences prior to the age of 18. And again, this does not include any traumatic experiences in adult life. Some statistics from specific to North Carolina. A group did their own study in 2012 and found here in North Carolina, 15% of adults reported a childhood trauma involving physical abuse. Almost 29% reported a trauma involving emotional abuse. And almost 11% had a trauma involving sexual abuse, all before the age of 18. Those were North Carolina statistics. So likely your clients, your residents, your participants have had a trauma in their past. and how you respond does make a difference. I will also add that needing to live in a nursing facility, maybe living in the need to live in an assisted living facility, or needing in-home care likely includes a significant loss and maybe also a traumatic event. A true or false question for you. Feel free to put your answer in the chat box if you'd like. Heart disease costs the United States more than trauma. True or false? I'll also go ahead and give you another piece of information. So, heart disease costs $300 billion in the United States. Trauma costs $671 billion a year in healthcare and lost productivity. Again, 10 to 20% of people who experience a traumatic event will go on to develop post-traumatic stress disorder. The chronic nature of post-traumatic stress disorder, as well as common medical illnesses and social cost, make it a significant public health issue. Trauma can have a ripple effect. It impacts a person's mental health. When we learn more about the ACEs study, we will hear how trauma can impact a person's physical health, and it can impact their relationships. Specifically, it can look something like this. A man develops post-traumatic stress disorder due to a traumatic experience he's had. Due to the post-traumatic stress disorder, he needs support in managing his symptoms to be able to function as a husband, a father, a grandfather, and a volunteer. Managing his symptoms can mean learning healthy coping skills to manage his irritability, so he is not regularly drinking to intoxication or yelling at or hitting his spouse or grandchildren, thus potentially inflicting a physical injury and or creating another traumatic event. So why trauma-informed care? Because you and your coworkers and your staff, your community can and do make a difference for the folks that you serve. Now let's learn some more about trauma. These are the 3 E's of trauma: event, experience, and effect. So the event can include circumstances, actual or perceived threat of physical or psychological harm, such as a natural disaster, violence, or severe life-threatening neglect for a child that impacts healthy development. These events and circumstances may occur as a single occurrence or repeatedly over time. This type of event is required for a diagnosis of PTSD. Experience. The person's experience of these events helps to determine whether it is traumatic or not. A particular event may be experienced as traumatic by one individual and not for another. For example, if siblings are removed from their home due to abuse, one sibling may experience the removal from the home as a traumatic experience, and the other one may not. Or one military veteran may experience deployment to a war zone as traumatic, while another one may not be similarly affected. How an individual labels or assigns meaning to and is disrupted physically and psychologically by an event will contribute to whether or not it is experienced as traumatic. Traumatic events, by their very nature, set up a power differential where one entity, whether it's an individual, an event, or a force of nature, has power over another. For example, this pandemic that we've been in. This pandemic has had power over all of us because we didn't know it was coming. We didn't know how to protect ourselves from it, and we didn't know how to treat the illness. So the individual's experience of these events or circumstances is shaped in the context of this powerlessness and the questioning. Feelings of humiliation, guilt, shame, betrayal, or silencing often shape the experience of the event. When a person experiences physical or sexual abuse, it is often accompanied by a sense of humiliation, which can lead the person to feel as though they are bad or dirty, leading to a sense of self-blame and shame. Moving on to effect. These harmful effects may occur immediately, or there may be a delay and they may start days or weeks later. The effects can last a short period of time or can become chronic and long-term. In some situations, the individual may not recognize the connection between the traumatic events and the effects of the traumatic events. Examples of adverse effects from a traumatic event include an individual's ability to cope with normal stresses and strains of daily living, includes impacts their ability to trust and benefit from relationships. It can impact their ability to manage cognitive processes such as memory, attention, and thinking. It can impact their ability to regulate their behavior or to control their expression of their feelings or emotions. In addition to these more visible effects, there may be an altering of one's neurobiological makeup and an ongoing health and well-being. Advances in neuroscience have documented the effects of such threatening events. Traumatic effects, which may range from hypervigilance or a constant state of arousal to numbing and avoidance, can eventually wear a person down physically, mentally, and emotionally. So these are the 3 E's of trauma that, that talk about how a person experiences it, the significance of how a person experiences it, and talk some about the effects of traumatic events. Now we're going to get more into the ACEs study. This study, this video gives the basics of the study and its findings. This study surveyed or questioned more than 17,000 adults across 25 states here in the United States. And the lady that you will see is a doctor from California who finally learned about this study and then started using the information in her practice. And now I'm going to switch screens.
And let's see if we can hear it. Give me a thumbs up if you can.
No.
Let's see. Let's try one more time.
Experiences study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window.
Okay. So that video is, the whole video is wonderful. It's just chock full of wonderful information. But in the interest of time today, we didn't have time to watch all of it. But I wanted you, she does such a good job of getting to the nitty-gritty of why this study was important and the impact of childhood trauma on us, not just as children, but in our adult lives too, and how this study shows us that childhood trauma not only impacts our mental health, but it seems that it can impact our physical health as well. You know, she talked about the fact that repeated trauma and stress can change brain structure, how somebody with 4 or more ACEs has a higher risk of COPD than the general population. Somebody with several ACEs is 3 times more likely to develop lung cancer. So, and then the other thing I will remind folks is this study did not include medical traumas. So I bring that up just to say that there is the potential for other traumas that weren't included in this study. So we know this study helps us to see that trauma is way more widespread than we thought. And so that's one reason for trauma-informed care. But then also the long-term impact of childhood trauma, and that doesn't include any adult traumas. So this slide goes over some of the statistics that she mentioned. These came from the ACEs study. The things that we found out from this study forces us to accept or respect the significant impact trauma can have on people and their functioning. It leads us to take steps to prevent trauma and re-traumatization. The potential for triggering or re-traumatization exists in all systems, and in all levels of care, individuals, staff, and the system, the community, the company. Thus, the reason for trauma-informed care. Another example of a potentially traumatic experience that can lead or occur before people end up in your care, if you are working in long-term care, is being in the intensive care unit. A study from 2019, and this was pre-pandemic, mind you, a meta-analysis looked at 48 studies, and in those 48 studies, there was a total of just over 7,000 patients that they looked at. They found that 1 in 5 adult survivors of critical care develops post-traumatic stress disorder symptoms in the year following discharge from ICU. So again, 1 in 5 adult survivors of critical care develops post-traumatic stress disorder symptoms in the year following intensive care discharge. So something else for us to be mindful of, not only because we're working with the geriatric population, but also because we hope we're coming out of this pandemic where so many people have been in intensive care. And so you may, something to think about if you have a new client resident who spent time in intensive care, especially during the pandemic. Now we're going to move into exactly what is trauma-informed care, or you might hear it called a trauma-informed approach. Well, let's start with what it's not. It's not trauma-specific services. It's not therapy or counseling. It's not treatment for the effects of trauma. Trauma-informed care means that we stop thinking to ourselves, what is wrong with this person? And we begin asking ourselves, what has happened to this person? We know from the ACEs study that 61% of adults had a minimum of 1 traumatic experience prior to the age of 18, and 16% had 4 or more. This approach is used for those with post-traumatic stress disorder and those without post-traumatic stress disorder. There are other traumatic stress diagnoses in addition to post-traumatic stress disorder. So again, and also remembering that just because somebody has experienced a traumatic event doesn't mean that they're going to develop post-traumatic stress disorder. Trauma-informed care recognizes that residents or clients may be coping with those issues in ways that are not obviously connected to those traumas. This means that ways that they may respond to things or to people may not make sense to us, but it may well be connected to the trauma from their past. Re-traumatization is any situation or environment that resembles a person's trauma literally or symbolically, which then triggers difficult feelings and reactions that go back to the original trauma. And it's often very unintentional. Some examples of triggers include a song that may have been playing, or the smell of cookies that may have been baking while a female was being molested. That song, the smell of those cookies, can turn into a chronic trigger for her. A person coming around a corner can become a trigger for someone who survived an assault. Trauma-informed care promotes an environment that supports healing and recovery rather than unintentionally re-traumatizing someone. So have you thought about things like power dynamics? So let's take, for example, somebody that needs to move into a nursing facility or an assisted living facility. They don't get to make all of their own decisions anymore. Their decisions about food, room size, room color, and meal times, for example, are limited. If they need assistance, their decisions about when to get dressed, when to brush their teeth, are limited to availability of staff to assist them. So this community or company has power in the situation because the community or the company ultimately decides meal times, menus, color of walls, etc. If your staff is too busy, folks have to wait maybe 30 minutes, maybe an hour to get dressed for the day. Residents can feel like they can't speak up for fear of reprisal, discrimination, or discharge. For someone who grew up with a severely neglectful parent, this situation, lack of choices, having to wait to have physical or emotional needs met, can feel the same to them as when they were a child. And we've got some other examples of loss of privacy, whether somebody is moving into a long-term care community, or if they suddenly find themselves needing in-home assistance, removal of clothing, gender of staff, physical touch in intimate areas, feeling a lack of control, For someone who grew up in a severely neglectful environment, or for somebody who grew up with a parent who abused substances, feeling a lack of control is common, is very common. And in COVID-19 times, in this pandemic has been both traumatic for some people and triggering or re-traumatizing for others. So, what can you do? I'm glad you asked. So anybody that attended Centralina's sex abuse and long-term care training last week has already heard Lori Abinader talk about training and more training. That is a great place to start. So continue to do what you are doing right now. Educate yourself on trauma. Provide training on trauma to all staff. Even management and administration need to know about the impact of trauma so they can create appropriate policies and procedures and support frontline staff, as well as residents, participants, or clients. Give staff opportunities in supervision to reflect and process challenging interactions with trauma survivors that you are serving. Assist your staff in building skills around empathy, compassion, comfort, and connection with survivors who are in distress. Encourage staff to use self-care. It will help them to be more patient and compassionate staff. And remember, you will have staff who are survivors also. Consider your environment, your processes. How might participants or residents or clients experience your services or your intake process? Does your intake process demonstrate accessibility and in being inclusive of people with complex mental health concerns or people in recovery? In your intake process, is there enough time and flexibility to take breaks, to read questions to people who might need that, or to complete your intake in more than one session if it's overwhelming for them? What changes might you need to make to your intake process, such as the length of your intake process, the wording of the way that you word policies and procedures, or the way that you word questions that you ask clients, residents? Be respectfully curious. This includes asking what is helpful to them when they are in distress, as well as asking what is not helpful when they are in distress. Are survivors of traumatic experiences given plenty of time and space to share experiences with staff? And if they choose not to do so during the intake process and it comes out at a later date? Is your staff able to hear it without expressing frustration or irritation that they didn't share sooner than they did? Allowing people to develop a comfort level with the environment and with the staff leads to them being comfortable to sharing sensitive information such as traumatic experiences. Before survivors disclose anything, do staff members understand and are they able to share with a client or a resident the extent of confidentiality and the limits of confidentiality, mandatory reporting requirements? Are they able to talk about what is going to be done with the information, where it will be kept, and who will have access to this information? Pay attention to language. Pay attention to language that is judgmental. For example, if you say someone is being non-compliant, it might be that their behavior that they are displaying is actually a trauma response. And again, these are just some very basic, very beginning steps of how to start implementing trauma-informed care in your company or your community. We could talk a lot more. There's a lot more information out there about how to implement. I wanted to give at least one example of some trauma-informed care services. Child advocacy centers were created to prevent re-traumatization. A child advocacy center is where an abused child is interviewed by one trained professional and, if needed, examined by one medical professional. And then the information is shared with the different professionals, social workers, detectives, district attorneys, who need it to provide services to the child and family. This prevents the child and family from having to tell their story several times to different professionals. The telling of the story over and over can be re-traumatizing. And there's also the National Drug Court program is another good way of how we have created a program with some basic understandings in place of how people are going to respond and react. But in the interest of time and to give folks opportunity to ask questions or make comments, I'm going to stop there. And just quickly in summary, are traumatic experiences common? Oh, yes. 61% of people have had a minimum of one traumatic experience prior to the age of 18. And those experiences that they surveyed for didn't include medical traumas. It's only traumatic when there is physical harm or injury. It's only traumatic when there is physical harm or injury. That is false. A traumatic experience does not require physical harm or injury. True or false? Trauma-informed care means asking, what is wrong with that person? That is false. Trauma-informed care does not ask what is wrong with that person. Instead, it asks what happened to that person. Does trauma-informed care assume that people have a trauma history? Yes, trauma-informed care does assume that people have a trauma history. No choices, no way to voice desires can feel like a past history of abuse or neglect. True or false? That is true. Not having choices and not being able to voice desires can feel like a past history of abuse or neglect. Do we have questions or comments?
Hi, Kara. At this time, I do not see any new questions or comments. I think we've had some throughout, but I think one person asked if we could repeat the number, but I believe you captured that in your summary there towards the end. So I think that's been covered. So I'll encourage everyone, if you have a question, this would be the perfect time to add that to the chat.
Mm-hmm.
I'll also mention that we did include the link to the video that Kara showed. The link is in the chat if you would like to copy that, so you can view it at a later point. Someone commented that they had seen that video before and felt that it was very informative.
I agree. I appreciate the study. Being a licensed clinical social worker working in behavioral health, I really have appreciated the study, and I really appreciated the way the doctor was able to explain it so well.
Absolutely. We had a question about, are support groups helpful for persons who have experienced trauma?
They can be. They can be, especially when the group keeps a positive focus. As we've talked about, people repeating their story can be re-traumatizing. And then also hearing other people's stories can be traumatizing. So a support group can be helpful as long as it's as long as they're not continuing to talk in great detail about what they experienced, and as long as they are also talking about ways that they cope and giving hope that they can cope, that people can learn to cope. So yes, it can be helpful with some conditions attached.
Thank you, Kara. Another question, do you think that dreams or hallucinations in the elderly can cause them to believe they have had trauma in the past?
Dreams or hallucinations. Do I think it's possible? Yes, I would say that it's possible. I would also remind folks that people who have had trauma in their past, when they're going through a dementia, They can, for lack of a better term, re-experience it as they're going through their dementia journey. And sometimes they may talk about it as if it's happening now. So it is also possible that, that something that has happened to them in the past, they can be re-experiencing it in their journey through dementia.
I would agree with that based on what I have seen in my years working with older adults, many of them who had dementia. We would see someone who had specific types of behaviors and reactions to being dressed or disrobed by someone to receive care, being bathed. And after a while, we were able to figure out through conversations with family members, because the resident could not share that with us. And the family members did actually share and confirm that this individual had been a victim of a sexual assault in her early 20s and that she was reliving. Are there, and this was actually just the question I was about to ask, and Kevin Edwards Knight asked this, and it's a great segue. Are there specific therapy modalities that are more helpful than others?
For trauma, yes. EMDR, eye movement desensitization. I'm sorry, I'm forgetting what the R stands for, but EMDR shows good effectiveness. Cognitive behavioral therapies show good effectiveness. And I have to also add that things like activities like mindfulness, deep breathing, exercise, yoga, meditation are also, research shows us that those things are helpful, not that they're going to eliminate the impact of the trauma, but those things are helpful. Those things help to kind of reprogram the nervous system. And what am I trying to say? Reprogram the nervous system. So when the trauma happens, it changes the nervous system, and the mindfulness, the meditation, the yoga, the exercise helps to reprogram the nervous system so that it doesn't have the same traumatic responses. So yes, there are therapies that are helpful, but there are also some alternative ways for people to help deal with the reactions to trauma.
Great. Any other helps? I think we covered the questions. Oh, Caitlin, if you could, are there certificates of attendance that we normally give out?
Yeah. So we'll send a follow-up email. It'll have Kara's PowerPoint. You'll have a certificate of attendance, and then a link to where this recording will be on our website as well. So you'll get all that information in an email.
Wonderful. And I'm also adding to the chat, there is a resource that I have found that is really helpful, would certainly be helpful to use as a training resource if you have staff who work with clients or residents in a facility setting. So I'm going to add that in the chat as well. And I think we have one last question from Lily Hackman. When it comes to trauma therapy, specifically EMDR, would it be beneficial for individuals who also deal with challenges such as memory loss PTSD, or would a different therapy provide a better outcome?
I'm thinking. So first of all, it's going to depend, how far into their dementia journey they are. If they are, and let me also say, we don't have a whole lot of research on this. So if it's a new trauma for somebody who is in the very early stages of dementia, yes, I think EMDR would be helpful. In the later stages, I really don't know what to say, just because if there's research out there about it, I've not seen it.
Okay, great. Well, I think according to the clock, I believe we are just out of time, and I want to thank Kara again for joining us. She has been a presenter for us quite a few times, and I know that she's provided you all with a lot to think about, and I appreciate everyone for being here, and just want to express our gratitude for your support and joining us. Caitlin, do we have some final announcements for any additional trainings? And again, Kara, thank you very much for being here with us today. We've enjoyed it and always enjoy the information you share.
I enjoy working with y'all too.
Absolutely. Thank you for being here. Just my one last thing I threw in the chat, where to register for any upcoming webinars. But other than that, thank you, everybody. Thanks for coming.